So next slide, please. These are my disclosures. So case number 1. This is a 55-year-old woman with high-risk multiple myeloma. She has a translocation 1114, as well as a deletion 17p. Shown here is her treatment history. As you can see, this patient, would be considered penta-refractory, having received proteasome inhibitor, immunomodulatory agent, autologous stem cell transplant, and more recently, venetoclax, bortezomib, and dexamethasone, and is progressing. Next slide, please. So for our first question, based on the data that we saw from Dr. Kumar, which of the following targets would be most promising for this quad refractory patient? Okay, great. So for those of you who answered all of the above, you are correct. And let's move to the next slide. So all of those mentioned targets, I think, are quite promising. Currently only BCMA has an FDA approval with belantamab mafodotin, but we saw very high overall response rates with teclistamab, which is a BCMA bispecific antibody. Again, seeing impressive results with the CAR T therapy, the CARTITUDE-1 trial. And then highly promising data from other new targets we haven't seen in myeloma, GPRC5D, FCRH5, and then briefly mentioned was cereblon and iberdomide, and also CC92480. Next slide, please. So the CARTITUDE-1 trial, as we saw earlier, had very high overall response rates, and apologies for the typo on the prior slide. That's actually nearly 97% overall response rate with a very high proportion of stringent CRs and a median PFS that was not reached. Very impressive results. This is a murine CAR T, similar to the BB2121, but it has 2 binding epitopes, which may account for the greater efficacy. It's hard to do cross-trial comparisons, but yes, very exciting. Next slide, please. Teclistamab is a BCMA bispecific antibody or T-cell engager. And remember how these drugs work is one arm of the antibody binds to the T-cell, which is CD3. The other arm binds to BCMA. And that causes activation of T-cells, which results in induction of apoptosis in cancer cells, such as plasma cells in this case. And teclistamab showed high overall response rates at the recommended phase 2 dose, which is shown here, 73%, with a high proportion of patients who are penta-refractory. Next slide, please. GPRC5D is a very interesting target. It is universally expressed on plasma cells. It is also expressed on hair follicle cells, interestingly. And this is early data from the translational work where this target was first described, showing very high proportion of plasma cells that express this target. Next slide, please. Talquetamab is the first-in-class drug that is targeting this protein. It's a GPRC5D T-cell engager. This data were presented fully at ASH, but with, again, heavily pretreated patients. 15% had prior BCMA-directed therapy, with a very high overall response rate, again, with the caveat that this is an early phase study, and that, the inclusion-exclusion criteria for some of these studies, I think may result in some selection bias with the population, but again, very encouraging with cytopenias, CRS, and neurotoxicity, as well as dermatologic side effects, which is not surprising given the expression profile of GPRC5D. Next slide, please. And then finally, FcRH5, which is a B-cell-specific marker highly expressed in MM cells. This was the first study of a T-cell engager targeting FcRH5 with an overall response rate, again, mirroring some of these other agents that is quite high, including responses in some very high-risk patients. Again, CRS, cytokine release syndrome, also quite common, but it was uncommon to have grade 3 or more severe CRS. Next slide. So with that, we'll move on to the next case. So we are seeing a 61-year-old gentleman with newly diagnosed IgA lambda multiple myeloma, revised ISS2, Dury salmon stage 3A. His fish show a deletion 13, and he has a conventional hyperdiploid karyotype by conventional cytogenetics. Next slide. Which of the following would be most optimal to achieve the deepest response and the best progression-free survival with respect to treatment? And I'll read out the options. Proteasome inhibitor, IMiD, steroid induction, followed by autologous stem cell transplant and immunomodulatory agent maintenance. DARA KRD for 12 cycles, no transplant, followed by lenalidomide and carfilzomib maintenance. DARA RVD induction, autologous transplant, daratumumab, lenalidomide maintenance, and options A and B. So interesting, and I guess this is not too surprising to see some variability in the responses here. I really think that, the way the question was worded, I was trying to highlight, progression-free survival as well as overall response. For those of you who chose DARA RVD, that is a highly effective induction regimen. But as we saw from the data Dr. Kumar presented, the progression-free survival was still not different between the DARA RVD versus the RVD arms. So the correct or the most accurate answer, I think would still be to say RVD induction, followed by autologous stem cell transplant and lenalidomide maintenance. And these were the data that were presented from the IFM data, the updated analysis that showed improvement in progression-free survival. Interestingly, even amongst the MRD negative at 10 to the minus fifth patients, comparing RVD plus transplant versus RVD alone, there was an improvement in PFS, even if you got to MRD negativity, suggesting that there is some deeper reduction of disease burden or perhaps some immune modulatory effect of the transplant that is taking place that yields better responses even amongst the MRD negative patients. The Forte trial, a very important trial that we heard highlighted earlier with 3 arms, still showed a significant benefit with respect to progression-free survival for the inclusion of transplant after KRD induction. However, overall survival was really not different between any of the arms to date. So next slide. So next case, we are seeing a 56-year-old gentleman with a history of IgD kappa multiple myeloma. He is evaluated after treatment with BCMA CAR T cells, to which he has had no response. Shown here is his treatment history: RVD, autologous stem cell transplant, carfilzomib maintenance, pomalidomide and dexamethasone, daratumumab, pomalidomide and dexamethasone, venetoclax, bortezomib and dexamethasone. This patient also had a translocation 1114. And then patient had BCMA targeted therapy number 1, which was a BCMA antibody drug conjugate, and then had treatment with BCMA CAR T cells. Next slide. So we didn't cover this in the slides, but I think this is important. And what is a possible mechanism of resistance to BCMA targeted therapy? Not just CAR T cells, I suppose, but any BCMA targeted therapy. And so option A would be decreased surface expression of the target or antigen escape. B would be clonal selection of a BCMA deficient malignant plasma cell population. And C, T cell exhaustion, or D, all of the above. Excellent. So for those of you who chose D, which was the majority, that is correct. All 3 have been hypothesized to play a role in resistance to BCMA-directed therapy. Why do BCMA CAR T cells stop working? And I think this is a generalizable argument to all CAR T therapy. T cell exhaustion as defined by certain markers and certain subpopulations that are less effective at mounting an immune response against the malignant plasma cells. Loss or downregulation of target antigen, and we presented data from our study at Fred Hutch showing that inhibition of gamma secretase could increase surface density of BCMA. And then very interestingly presented at ASH by colleagues from DFCI, biallelic deletion of BCMA from chromosome 16. Next slide, please. Shown here is the data from that presentation, which I think was one of the most fascinating that I saw this year. This describes a patient who was treated with BCMA CAR T cells, relapsed, and a retreatment was attempted, but the patient did not respond. And they noticed the patient had virtually no soluble BCMA, which is the byproduct of cleavage of BCMA from the surface of plasma cells. When they investigated further, they discovered that the patient had a deletion 16p. 16p is the part of the place in the genome where BCMA is located. So in that case, one loss of the BCMA locus. The patient also had a mutation of the other copy of BCMA, resulting in basically no BCMA production at all. And so I think this is a mechanism of resistance that definitely deserves more attention. And I think more research will be needed to define how often this occurs and could explain resistance in patients. Next slide, please. So for the final case, we have a 67-year-old woman with newly diagnosed immunoglobulin light chain AL amyloidosis with a lambda clonal plasma cell dyscrasia. The patient has cardiac, renal, and gastrointestinal involvement, stage 3 by the Mayo staging system, not currently eligible for autologous stem cell transplant. So here we're diving into amyloid, which I know we did not cover in some of the prior presentations, but I think it's important to provide some updates. What would be the most optimal therapy for the achievement of a deep hematologic response? And feel free to just type in anything that comes to mind here. No wrong answers. Give everyone a few minutes to do that. All right. So let's look at some options here. Option number 1 would be the combination of bortezomib, cyclophosphamide, dexamethasone, Scoreboard, or sometimes called VCD, lenalidomide, bortezomib, and dexamethasone, daratumumab, cyclophosphamide, bortezomib, and dexamethasone, or Scoreboard, or finally, melphalan and prednisone. So everyone choose the best answer for what would help achieve the deepest hematologic response. Great. Well, that's very encouraging. So for those of you who chose Scoreboard, I think that is probably the best data-driven answer. We saw an update by Dr. Comenzo from the Andromeda trial, which was a randomized phase 3 study for patients with newly diagnosed AL amyloidosis, with the 2 study arms being number 1, daratumumab plus Scoreboard, daratumumab being the CD38 antibody that we're familiar with from multiple myeloma, with the standard of care of Scoreboard, as compared with Scoreboard alone for 6 cycles. The primary endpoint of the study was MOD-PFS, which is a composite endpoint that looks at not only hematologic progression, so progression of free light chains, monoclonal protein, but also organ deterioration, which is particularly important in AL amyloidosis. What we saw in the Andromeda study was improvement in MOD-PFS amongst the patients who were treated with Scoreboard, but also very deep hematologic responses as shown here. And I'm sorry for the small size of this, but involve free light chain less than 20, or the difference in the free light chain less than 10, which are important parameters that are indicative of hematologic response and prognosis in AL amyloidosis. So Scoreboard, I think this further cements evidence for use in newly diagnosed AL patients who are transplant eligible or not, frankly. So I think that is my final slide. Thank you very much for the opportunity to present and administer these questions. And we will finish up.